Osteopetrosis. Osteopetrosis, this is a very rare disease, as you know. And the aim of this lecture is not osteopetrosis, because I want to tell you something about histology and about embryology. Pathology of bones are connected with embryonic development, but not always, and not only. So osteopetrosis is just signed today, just to provoke us to discuss about bones. And first slide is about everything you know, but in Polish. This is about tissue. You know that we have 4 types of tissue. This is connective tissue, epithelial tissue, muscle tissue, and nervous tissue. All of them are connected and they cooperate to each other to have results in skeletal system. In skeletal system, we have bones, as you know. Bones are example of connective tissue, which has some cells, but the most important is extracellular substance. This extracellular substance is very hard, yes, very difficult to provide vessels, arteries, and nerves. Quite easy and a lot of space we have in fibrous connective tissue. In this tissue we have some cells and a lot of fibers which are in extracellular substance. But in bones we have to have special channels to make way for vessels and for nerves. So blood, this is next type of connective tissue, which is part of skeletal system. In a wall of vessels we have epithelial cells, so next tissue. As we know, all types of tissues are in skeletal system. Very important information about skeletal system is that it can be remodeled. Changes over a lifetime are connected to some fractures, of course, but very often to not correct body position. Yes, for example, in children which use computer, their body position is not correct. So skeletal system is rebuilt, is remodeled to it. Sometimes it's very healthy, sometimes it makes some pain. On this same we can see a remodelation of bones, long bone. Of course, to make this remodelation, the skeletal system should, bones should cooperate with other organs, all organs which are in a body. So such, for example, fracture, this is main or this is problem for all organism. And first step is hematoma and granulation tissue, next cartilages, callus, next bony callus and cartilages ermans, and the last is remodeling. Of course, we can see that this remodeled bone is a little bit different than normal bone, but function is the same and quite often is without pain. Functions of bone, support, this one you know, protection. We have some organs in our body which needs protection, for example, lungs, which needs protection of ribs. Movement, bones are places in which muscles are connected and they take part in movement. Hemopoiesis, you know, because of bone marrow, and we can we produce blood cells in a bone marrow. And a very important role of bones, they are act as a place for storage of minerals. Most than 90% of the body's calcium and phosphate is stored in bones. Of course, calcium and phosphate are important to special calcium to start construction of muscle, to make blood clotting, to start impulse transmission in nerve system. Bones as well are places for phosphate as a place when ATP is utilized and nucleic acid, DNA, RNA as well use this phosphate. As well, bones are reserves of energy in marrow. And on this scheme, we can see histology of bone. This histology, you know, this is just a repetition from histology because, you know, second year of study, you finished histology, and on the first year we finished tissues in a histology course. So you know everything about it, but now in English. Bone is covered by a periosteum, and I want to remind you that this periosteum consists of two layers. One, this is fibrous layer with collagen, elastic fibers, and cellular layer. And this layer is bigger on the right side, and I tell you about this layer in some minutes. Periosteum is connected to lamellar part of bone by perforating fibers, which of course originate from connective tissue. In lamellar bone, we have special lacunes with small canaliculi, and those lacunes are for cells, mature adult cells of bone. These cells are known osteocytes, and their shape and size is completely the same like those lacunes. Long pieces of cytoplasm are used to take oxygen and nutrients from very far places. On the right side, we can see the cellular layer of periosteum, and here we have osteoprogenitor cells. They are cells which will be originated and will be divided into osteoblasts. Osteoblasts are still not mature cells. They are a little bit smaller than osteoprogenitor, and after growing, after differentiation, a result is osteocytes, which are in lacunes, I told you. And on this picture as well, we have very big cell. This is osteoclast, but this cell originates from connective tissue, not from epithelial tissue. And now this very simple way from osteoprogenitor stem cell via osteoblast, which is immature, and to osteocytes, which as you can see is quite small, but has very long pieces of cytoplasm to find nutrients and oxygen. And now macrophage. Macrophages, of course, as you know, they are cells of connective tissue. And in each organ, they have different names. And in the case of bones, their name is osteoclast, which is characteristic that those cells are very big. What else? They have a lot of lysosomes. Why? Because lysosomes, as you know, takes part in digestion. They have hydrolysis and contain hydrolases, and they can digest lipids, proteins, sugar, nucleic acids, so almost everything, and divide it into small, simple pieces. So, for example, proteins into amino acids. Main function of osteoclast. This is phagocytosis of deaf cells. Sometimes those deaf or not correct cells are osteocytes, and sometimes, as on this picture, are blood cells which are incorrect. Bone consists of two big groups of ingredients, organic components, which take 1/3, and inorganic components, 2/3. Organic, it is obvious, of course, because organic components are mostly cells. And as you can see in connective tissue, which is bone, extracellular substance is a little more bigger than cells and organic components. So apart from cells, we can see some proteins which are in fibers and some ground substance. 2/3 inorganic components, calcium phosphate, hydroxyapatite crystals, calcium phosphate, and calcium hydroxide. Two types of bones we can distinguish: compact bone and spongy bone. Both we can find in simple long bone. Once again, on the left side, we can see periosteum. In compact bone, we can see some lamellae. They have two types. They make two types. First are external circumferential lamel, which is very close to periosteum, and inside we have osteons, which are known as the Haversian systems. In this osteon we have central canal, and in this canal we have nerve, we have vein, artery. Those canals are longitudinal, but as well we have transverse channels which are known as a perforating channels. Inside, in long bone, we have a spongy bone. In it we have a lot of space to produce bone marrow. It means cells of the blood. Ossification and osteogenesis. So now some embryology of bones. Ossification, osteogenesis, this is formation of bone and their development. Begins in embryo by 8 through 12 weeks. And as you remember, we have two types of ossification. From mesenchyme, or second type from hyaline cartilage models of bone. About them I will tell you in some minutes, but of course this ossification starts in embryonic development but continued during childhood and adolescence, as you know, till a person is old, about 25 years. Now a little bit longer slide, because I want to remind you about two types of ossification. First type, intramembranous ossification. It seems like quite easy ossification. It's not on a model because this starts on mesenchyme. And on the beginning, we can see first picture on the left side. We can observe making ossification centers which are inside in mesenchyme. In this moment, osteoprogenitors, so it means stem cells, they start to develop. They start to divide themselves, and they start to become osteoblasts. Step number two, osteoid. This is bone matrix which calcifies, and in this moment osteoblasts start to be osteocytes. Next we observe formation of lumen in blood, and veins, arteries are connected to the bone and start to transport oxygen and nutrients. This is primary bone. And the last, lameral bone, secondary bone, we can see compact bone and spongy bone, which is inside. Second type, second possibility to make ossification, this is endochondrial ossification. On the beginning, we have formation of cartilage. Cartilage models develops started from chondroblasts. They become to be chondrocytes. No, and we can see formation of perichondrium. A very important step in it is that cartilage is not connected to veins and arteries, so nutrients and oxygen can take only one cell from another cell. Next step in development of cartilage is calcification of this cartilage. Chondrocytes start dying. This is hypertrophy, and we can see a lot of osteoblasts, which are first cells of the bone. Once again, I want to remind you that they are immature. They are not differentiated yet. About 12 weeks of gestation, we can observe primary ossification centers, and this is known as the periosteal bud. In this moment in the bone, we have osteoblasts and blood vessels. Next step is secondary ossification centers, and they we can find in epiphysis. And some of them still we can find in children. Cartilage is replaced by bone, except some places. There is no bone in auricular cartilage epiphyseal plate, and this epiphyseal plate will be quite long in children, and we use it to we will use it to observe development of skeletal system in children. This epithelial plate ossifies about in people which has about 25 years. The last bone which finish ossification of epiphyseal line is clavicle. In these two ways of ossification, some bones prefer to be during development in this way. For example, flat bones of the skull or facial bones, mandible, for example, central part of clavicles are bones which ossificated in intramembranous way. And angiochondrial ossification, so it means ossification on cartilageous model, most of the other bones of skeleton. Pathology of bones are divided into 7 groups. Only one group is pathology of bones, which started in embryonic life. Between others, in this group, we have osteopetrosis. This is I want to tell you about it today. In postnatal life, we have some reactive diseases, we have some inflammatory diseases, specific like tuberculosis, non-specific like osteomyelitis, for example, endocrinal diseases which are connected with overproduction of hormones from parathyroid glands and thyroid glands. Idiopathic diseases like Langerhans cell disease, which is known as a histiocytosis X, Paget diseases, fibrous lesions, for example, fibrous dysplasia, and of course, neoplastic diseases, malignant like osteosarcoma and benign like osteoma. What is result of not correct development of bones during embryonic life? It can be hyperplasia of bone. hypoplasia, sorry. It can be as well hyper and hypoplasia. Lack of bone, incorrect connection of bones, and pathological shape of bones. And and reasons of congenital bones diseases is, for example, abnormal production of bones components, excessive production of bone hypertrophy, or distortion with correct bone and cartilage. Developmental diseases, osteopetrosis. What else? Osteosclerosis fragilis generalizata, mandible bones, ivory bones, general congenital osteosclerosis. Those diseases are really very, very rare. So this is why I used this disease only because I wanted to tell you something about embryology and development of bones. Prevalence rates, you can see that it is really very, very rare. But what is mechanism of osteopetrosis? This disease is genetic, and we can see dysfunction of osteoclasts. This is why I told you about osteoclasts. I think that you remember that big cells, which are macrophages, and their function is to make phagocytosis or resorption of not correct cells, calcified cartilage, for example. They are very important during angiochondral ossification and intramembranous ossification. So if they not act correct, we can observe bones which are very dense. So what is result? That bones are quite long, may be correct if we are talking about they grow. Compact bone becomes very thick and hard. Spongy bones disappears. So what is result? That we have very, very small bone marrow, and quite often a symptom of osteopetrosis is anemia. Medullary activity is very, very small because is very narrow. This cavity. Osteopetrosis can affect only one bone, but quite often plenty of bones, and the most common is yaw, femur, radius, humerus, tibia, ribs, and vertebrae. There are not only symptoms in skeletal system, but as well, of course, result of it are pathologic fractures, of course, but as well, we don't have correct blood. So a lot of infections we can observe, cranial nerve pulse and blindness and deafness, strokes, delay or stopped tooth eruption, slow opacification and decreased blood flow to bone, which is very painful. Atrophy of bone marrow, result is hepatomegaly, splenomegaly, and enlarged lymph nodes. And of course, due to atrophy of bone marrow, we can see anemia and infection, which I counted on the beginning. What is in histology? I want to remind you this epiphyseal plate, which is for us important to analyze development of children, development of skeletal system in children. I want to remind you that this epiphyseal plate has 5 zones, but in osteopetrosis, we have very wide zone of calcified cartilage. Look at this picture, and you can see that calcified cartilage, this is zone number 4. In osteopetrosis, we can see very completely normal chondrocytes, thick cortex, narrow bone marrow cavity, full of calcified cartilage and primitive spongy bone. This primitive spongy bone is almost lamellar. the number of osteoclasts is normal, reduced, or increased. And as well, in microscope, we can observe anomalies of osteoclasts and cellular membranes in which covered osteoclasts. We have three types of osteopetrosis: malignant osteopetrosis, benign, and intermediate. The most strong is malignant, is genetically recessive. Is diagnosed immediately or shortly after birth. We can observe hematological difficulties, anemia, thrombocytopenia, granulocytopenia, or pancytopenia, blindness, deafness because of compression of the cranial nerve. Bone is very, very hard. Quite often pathological fractures and infections. And what is important that without bone marrow transplants, infants die during the first 10 years of life. Benign osteopetrosis is genetically dominant. Diagnosis we can make in adults, so we can patient can live with this osteopetrosis all life. In adults, sometimes we can see pathological fractures, osteomyelitis, pain, and degenerative arthritis and headache, and they are symptoms in which we start to make diagnosis, and we can see that this is benign osteopetrosis. And the last, intermediate diagnosis is made in the first decade of life. Symptoms are more severe than in benign osteopetrosis: blindness, deafness, hematological symptoms, and quite often break calcification, which leads to mental retardation. And we are almost on the end, because now I want to tell you some words about treatments. Sometimes we use antibiotics to regulate hematopoietic cells. If it's possible, we can treat anemia. We can try to prevent dental infection, and of course hyperbaric therapy. About it I want to tell you some words in some minutes. We try to make some different therapies using, for example, interferon gamma, calcitrol, this is active form of vitamin D, which stimulates osteoclasts and can help reduce bone density. Prednisone, or hormone which is similar to cortisone, to improve blood cells and platelet counts. Physical and occupational therapy to help children develop motor and other skill. Orthopedic care of fractures if they are balanced diet to support normal growth and development. Treatment is really very difficult, but we use a hyperbaric oxygen therapy to treat osteopetrosis. What is aim of hyperbaric oxygen therapy is to supply oxygen to damaged tissues and organs. Of course, in osteopetrosis, we have anemia, which is a difficult problem, sometimes lethal. And very important is to transport oxygen to very small bone marrow. So hyperbaric oxygen therapy, in which we breathe using 100% oxygen in hyperbaric atmosphere, is a very good idea and gives quite good results. Some examples of action of oxygen in the blood. Hemoglobin contains 1.98 milliliters of oxygen in 1 liter of blood when we check it in sea level. Plasma in this moment contains 0.00031 milliliters of oxygen in 1 liter blood on sea level. When on the same level we use to breathe 100% of oxygen, in the same blood we have in plasma 0.21 milliliters of oxygen in 1 liter. So oxygen is not only in hemoglobin but as well in plasma. When we use very high tension, let's say free atta, it means 1 atmosphere and 2 plus 2, which we add in hyperbaric chamber. So the same plasma can transport 0.68 milliliters of oxygen in 1 liter of a blood. So we can see how this is a big weapon to find with very small oxygenation of the body. Quite interesting that when a person is at rest, consumes 0.6 milliliters oxygen from 1 liter of blood, so without movement. So we use this oxygen a lot. And what is a function, what is mechanism of action of hyperbaric oxygen therapy? Contraction of blood vessels, so a result is reduction of oedemas. Stimulation of immune system, so a result is no infections. Antibacterial activity, because oxygen produces free radicals and activate leukocytes. Endothelial cell proliferation, so it means that we have neoangiogenesis, as well proliferation of fibroblasts, which, as you know, produce collagen, and it can regenerate, for example, cartilages. We have some contraindications to completely stopped hyperbaric therapy, pneumothorax, and treatment by using bleomycin, even in the interview, because result is fibrous lungs. And of course, we have some contraindications which are in this moment. Yes, for example, if someone is pregnant, has emphysema, convulsive state, so epilepsy, infection in upper respiratory tract, chronic sinusitis, cancer, doxoribosine treatment, disulfiram, cisplatin, till patients take it. When they stop the treatment, they can use hyperbaric therapy. We have some complication, but during our faculty, I will tell you how often we can find, we can have these complications. They are really very, very rare if you know rules and regulations. Barotrauma, it means high tension which can destroy middle ear, paranasal sinuses, inner ear and teeth. Oxygen has some toxicity, special in central nervous system, which can give some changes which are very short. And of course, oxygen as well can be toxic for lungs. Ocular complication like cataracts and of course claustrophobia, which makes hyperbaric therapy not for everyone. And this is the end of today's meeting about connective tissue, about embryology, it means development of bones, and some histologies of bones. And I told you some words about hyperbaric therapy, and we'll talk about it in our meeting during faculty in the same aim. So thank you. Thank you.